Good morning. My name is Dr. Robert Groysman, and I've been treating long COVID for approximately 5 years. Some wonder how I got started with long COVID, and it's definitely been a wild ride. I was treating PTSD with the Stellate Ganglion procedure, and we started seeing some patients coming in who had PTSD, but also had weird problems with their taste and smell, whether it was anosmia or parosmia, and they seemed to get better after the stellate ganglion procedure. That is where I started. This was back in early 2021, and it's definitely been a wild ride since then. I am an anesthesiologist and interventional pain management specialist by training, but I have definitely gone way beyond that when treating long COVID. I took it upon myself to research and learn about long COVID and COVID and to learn the mechanisms behind it. And the top four that I look at right now are dysautonomia, mitochondrial dysfunction, gut dysbiosis, and excess histamine or MCAS. So we will be getting into the questions shortly. I know that a lot of people want to get started. But before we do, I wanted to let you guys know that we just moved. We are now in West Plano. In particular, let me get my address because I still don't remember it by heart. It's 6957 Plano Parkway, Suite 2100 in Plano, Texas, and the zip code is 75093. Now, I left the west part of the West Plano Parkway because there's some kind of glitch in Google Maps. And if you type in the West or W, it takes you about 2 streets down and you won't find us. So I just removed the W or the West from the Plano Parkway if you're looking to find where our office is. So I know there's been a lot of buzz between or for the cGAS-STING pathway, and I found this to be kind of the missing link in explaining how long COVID causes the problems, and also long vax or the COVID vaccine problems, specifically the mRNA. So I wanted to describe to you first what all this means, okay? So what is cGAS? First off, it stands for cyclic GMP-AMP. And I know that also sounds really complicated, but it's a guanosine monophosphate and adenosine monophosphate, which are nucleotides. These are the parts of DNA and RNA that make up the 4 base pairs. So what this cGAS does is it's a protein, it's an enzyme. It sits in the cytoplasm of the cell. And if there's any presence of nucleic acid material, such as DNA or RNA, specifically double-stranded DNA, it particularly likes that, but it can be fooled by double-stranded RNA or even single-stranded RNA. When it senses double-stranded DNA or another form of nucleic acid in the cytoplasm, that is, something entered or something became present inside the cytosol of the cell. That is the inside membrane, inside of the double layer membrane of the cell. It acts as a sensor and it activates, and it combines with another protein called STING, which stands for stimulator of interferon genes. And they get together with IRF3, and which is an interferon regulator factor 3 regulator. So the next 2 pieces are what's called transcription factors. And what these are is when they activate, they go into the nucleus and they tell the DNA, the chromosomes inside your nucleus to unwind and start transcribing these genes. And the genes that they cause to transcribe are inflammatory genes or pro-inflammatory genes, such as the interleukins, such as cytokines, such as interferon. So once this process starts, it causes massive amount of inflammation. And this is how the cytokine storm starts during the initial COVID infection. Okay, there's so much nucleic material being released into the cytoplasm of cells that it causes a massive start of inflammation. So where does this DNA come from? Does it come from the COVID virus? Well, it actually doesn't. So COVID damages our mitochondria, and our mitochondria have double-stranded DNA. And when the mitochondria are damaged, they could rupture. And when they rupture, they release this DNA or leak the DNA through its membrane into the cytoplasm of the cell. And this gets the cGAS sensor very excited. So this is kind of how this whole process starts. And it really comes down to mitochondrial damage. Now, mitochondria are in pretty much every cell in your body, except mature red blood cells. So any place where you have mitochondria, there's an opportunity for them to rupture and start this cGAS-STING pathway process. And this process, actually, the inflammation and everything that happens from the innate immunity. This is not adaptive immunity yet, okay? So innate immunity, if we're talking about innate immunity, these are the cells that don't know what they're fighting. It's just they know something is wrong. It could be a cancer cell, it could be a virus, it could be bacteria, it could be a parasite. The point is they know something doesn't belong and they go to fight it. So that's part of innate immunity. Adaptive immunity is when you have B cells and T cells create specific binding sites for what they're fighting. They're only good for fighting that one thing. So B cells are the ones that make the antibodies, okay? And they're coded specifically to fight a specific pathogen, whereas innate immunity doesn't care. These cells go out there and they either gobble up the pathogens, or they release really, really nasty contents, like, for instance, mast cells. They're virtually a factory of toxins that when they release them in the vicinity of a pathogen, the pathogen just dies and dissolves. There's a ton of digestive juices and things that damage the membrane, things that damage DNA and RNA. I mean, mast cells are nasty. I mean, it's like a nuclear bomb. When you get a mast cell to degranulate. All right, I will open the forum to questions. You're welcome to post a question in the chat, and I'll be happy to answer them. If you guys don't have questions, I'll just continue talking. I know there were a lot of questions before. Okay, so we have a question here. Give me 1 second to read it. Is the stellate ganglion procedure safe for long COVID people with ME/CFS? And if you guys don't know what that is chronic fatigue syndrome and POTS. So yes, it is a safe procedure. In fact, I use it for people with chronic fatigue syndrome. And the reason I use it is because of the dysautonomia. So chronic fatigue syndrome is also associated with significant amount of dysautonomia that forms, and people tend to get stuck in fight flight. Okay, so it is safe, and I do use it, and it tends to correct POTS, which stands for postural orthostatic tachycardia syndrome. So the whole thing with that is this orthostasis. Things happen when you stand. Okay. And yes, that's also a problem with the dysautonomia or the fight flight. And yes, those things tend to be corrected post procedure. We have a question from M. Marquette. Does EAT treatment help with jackhammer esophagus? Let me first tell you what EAT is. It's epipharyngeal abrasive therapy. This is a procedure that has been pioneered in Japan. It has been around since early 1970s. It has not been adopted outside of Japan except by me. I saw the worth of the procedure and how it can help not just with long COVID, but also with chronic fatigue syndrome in reducing the dysautonomia from the mucosal part, which is the part in your nose and your throat where things get stuck in the mucus and continually stimulate this chronic inflammation. This procedure helps clean that out, clean out the cytokines that are stuck back there, clean out other things that irritate the back of your nose and throat. Even if you're not having symptoms, this can still cause and proliferate or propagate, I should say, the dysautonomia. I'm not exactly sure what jackhammer esophagus is, so if you can define that for me, I'd appreciate it. Long-term risks for either of the procedures. So I do several procedures. I do a stellate ganglion procedure, which is why I say stellate ganglion procedure, not a stellate ganglion block. It's different. They're not done the same way. So I don't just lump it together with a stellate ganglion block because it doesn't really explain what I do. And the EAT procedure, which is the epipharyngeal abrasive therapy. So we have a pretty good side effect and long-term side effect profile from both of these procedures. For the EAT procedure, as I said, it's epipharyngeal abrasive therapy. This has been done in Japan since 1970. So we know if there's any long-term side effects or problems or complications, and there really aren't. From the stellate ganglion procedure, the same goes true as well. If we're not talking about the immediate problems of the technique, that is the needle going someplace it shouldn't, and worse is injecting a local anesthetic someplace you shouldn't. There really aren't any long-term consequences of these procedures. So the idea of both these procedures is to halt the dysautonomia, okay? And the dysautonomia, specifically the fight-flight, is what is preventing your body from healing. So when you're stuck in fight-flight, this is about survival. This is about preserving life. And your body really only has two modes. It's either going to be in fight-flight, which is normally temporary and short-lived, or you're going to be in the regular mode, which is the healing, the recovery, the repair, the digestion, all the maintenance stuff that's supposed to take place kind of behind the scenes. And, you know, if you look at it from a fight-flight perspective, it's kind of like a turbocharger in your car. I don't know if you guys heard of a turbocharger. Some cars back in the day used to have them. I think some of them still have it. And the idea is behind a turbocharger is it increases the amount of air and oxygen that gets into your engine and gives you a boost of power. Well, that's kind of how fight-flight is supposed to work. Now, do you run the turbocharger down the highway the entire way? Basically turn it on and let it go. Well, there's consequences to that. You're going to wear out your engine doing that. So there's heat, there's stress, there's other things that are introduced into your body if fight-flight runs all the time. And that is unfortunately what happens in long COVID. So let me see here. So somebody, Stephanie, is asking about MCAS. And in her particular case, there's limitations of what she can eat. And she's really stuck mostly on potatoes and carrots. And there's many things that she cannot eat. So one of the hallmarks of excess histamine and MCAS is a sensitivity to foods, in particular foods that tend to either have a lot of histamine in them or cause your mast cells to release not just histamine, but basically other substances. Like I said, it's kind of like a nuclear bomb in there. So it's not really a good idea to have mast cells degranulate, which is release their contents inappropriately. So histamine does a number of things on to your system, including increase gastric acid. And the reason that this happens is that some foods, for instance, fermented products, okay, a lot of dairy products, they tend to have bacteria in there that are normally good for you, but they can also convert an amino acid called histidine into histamine. It's not that they're trying to hurt you, it's just part of their normal metabolic process, and it can increase the amount of histamine load your body is under. In addition to this, you can also have your own microbiome acquire bacteria in there that increase production of histamine. And lastly, you have elimination of histamine problems. So in other words, the enzymes that normally break down the histamine don't work well or don't work at all. And of course, mast cells can add to this problem by increasing the release of histamine. So the idea is to get you out of that histamine situation. So the way I usually handle this is not try to force new foods in, is eliminate the stimulation of the increase of histamine. So first thing is to stabilize the mast cells. Okay, and there's a number of ways of doing that, both through supplements and through prescription medications, and reduce the amount of histamine that is brought into your system. That is a low histamine diet. This doesn't have to be long term, but it does have to be long enough to get your body out of that state. Okay, I hope that helps. Justin, come on, Justin, you're not Justin Timberlake, okay? But Dr. Justin Timbershake. How long should you wait between SGB treatments? So again, I don't compare stellate ganglion blocks to stellate ganglion procedures that I do because they're very different. But if we're talking about in general, you can do stellate ganglion procedures every day. I've done them. I've done 2 or 3 a day for patients that required it. However, probably no more than two per day. You could do them every day if you wanted to, but your neck will tend to get sore if you do more than a few days of that. But there's no real reason to not do them. There's no contraindication to it, is what I'm trying to say. Alice is asking about apheresis. Her daughter is going to be having this procedure. So I'm not sure if she's referring to plasmapheresis or if she's referring to HELP apheresis. And HELP apheresis is the one that tends to be used for long COVID. The idea behind it is to remove or reduce the amount of fibrinogen, which is a component of our clotting system. It's one of the last ones, and fibrinogen becomes fibrin, and fibrin forms these bundles that form the clot. Okay, so that's way down. So to remove fibrinogen, it only makes sense if there's excess fibrinogen. In other words, fibrinogen is high. I don't believe that this is a procedure that's really useful for microclots or for removing spike proteins because it just doesn't. It really works on a lipoprotein that's removed, and it works on fibrinogen that's removed. Plasmapheresis works differently, and that can remove various antibodies that are circulating in your bloodstream. Okay, so for the most part, I don't see it as a useful procedure for long COVID unless we're targeting high fibrinogen Is it possible to treat the cGAS-STING occurrence to help reverse symptoms? So there's a few drugs that are being developed to inhibit and even enhance this mechanism, depending on what you're after. But there's nothing currently available to specifically target this pathway. There are ways to target it in more indirectly, specifically with the EAT procedure at the mucosal level and with the stellate ganglion procedure on the dysautonomia level. And if you're in my Facebook group, you would know that the top two things that I'm thinking is involved with this mechanism is the mucosa and the gut. So these are two places where this whole process starts, okay? The microbiome, when it's damaged or when these cells get destroyed, they also spill DNA, not just from their own nucleus, but also from the mitochondria. And similarly, in your mucosa, if you have any bacterial or viral components in there, when they're stuck in there, they're leaking nucleic acid material, and that could potentially start the cGAS-STING pathway. Okay, and I think all this starts from the mitochondria too. Again, from mitochondria being ruptured. And I hope somebody asks a question about fasting or prolonged fasting, because this is kind of where this fits in. So let's see. What do we got here? So Justin Timbershake is, I'm getting a kick out of that name. What is the best way to read your HRV? So let's define what HRV is. It's heart rate variability. So it's different from heart rate, okay? Heart rate variability is calculated, okay? It's not measured, it's calculated from beat to beat variations in your EKG. So basically going from, if we look at a QRS, the R part, the peak, we calculate the minute changes from the R to R intervals in your EKG. Now, this can be indirectly measured from something like a pulse oximeter that looks at pulses rather than EKG. But if we're looking at gold standard, it would come directly from an EKG, which means something like a polar strap or similar that would be put on your arm or your chest to actually get an EKG would be best or standard for measuring it. Okay, and the idea is we're not just measuring one distance. Okay, we're not measuring two distances. We're measuring multiple distances, the variation in distances, and this is in milliseconds. That's 1/1000th of a second. So that's not something we can actually measure ourselves. This is something we need a machine to measure. And ideally, we want 5-minute samples, and we get an average of the differences that occur. And then we want a daily average. Okay, so this is measured several times during the day. And then we want to know what the daily average is. We don't care about one number. Okay, if you have a 19, whoop-de-doo, big deal. 2 hours later, it could be 60. The point is we want to know what the trends are. And this gives us an indirect way of looking at our ANS state, or the autonomic nervous system state. Is it more predominantly leaning towards the fight or flight, or is it more predominantly leaning towards parasympathetic, which is what we want? And just to finish that question or finish that thought, low numbers are bad, high numbers are better. Okay? We want to see the variability there. That tells us that the parasympathetic nervous system is doing what it's supposed to be doing. Bill is asking about bouts of extremely loud buzzing in his head, and it's painful and causes headaches. Also has a question about PEM and chronic fatigue syndrome. So I'm not really understanding what buzzing in your head means. Are we talking about like tinnitus or tinnitus, where there's buzzing in the ears? Some people have tones, some people have buzzing, or are we talking about something else? Treatment for PAM, which is post-exertional malaise, centers around either fixing the dysautonomia or treating the mitochondrial dysfunction. It's typically caused by one or both of these things. And interestingly enough, chronic fatigue syndrome is also caused by both dysautonomia and mitochondrial dysfunction. So, Jessica is asking, can long COVID affect the skin, such as rashes and psoriasis? Well, yes, it can. Long COVID can cause manifestations of the skin in multiple different ways. One of the most common ways would be through the MCAS or the excess histamine pathway or mechanism. And this would more likely than not result in things like hives. So these are red, raised welts that itch. And they can occur on one part of the body, or they can occur on most of the body. Okay, when we're talking about psoriasis, that is an autoimmune condition, and I know we didn't get into that from the cGAS-STING pathway, but basically when this pathway is active for a prolonged period of time and you have chronic inflammation for a prolonged period of time, you start to recruit the adaptive immune system, and now you start making antibodies to things that are inside your body rather than to pathogens. And that is how we get the autoimmune part that happens. Now, so far nobody asked this, but ANA, anti-nuclear antibody. So normally things inside your nucleus, inside your cells, are immune privileged. That means the immune system doesn't really know they're there. And therefore, it hasn't really recognized it. So when a cell ruptures, or if mitochondria ruptures, anything that gets out and now is seen by your immune system and it has never been seen before, you can also make antibodies to the nuclear material. And that is part of how ANA comes about, these antibodies against nuclear material. And of course, you can also make antibodies to DNA and to RNA and to other things that are inside the nucleus that show up in diseases that involve the immune system or autoimmunity, right? And actually, somebody did just ask that. So that answers your question, okay? I hope. So Stephanie is saying that she's been on a low histamine diet for 3 months and is still reacting. So low histamine diet is only one component. So that means that you're intaking less histamine or less bacteria that produce histamine, but it doesn't really account for your own microbiome producing histamine. It doesn't account for mast cells degranulating inappropriately in your body, and it doesn't account for the improper degradation of histamine. In other words, histamine is not being destroyed properly in your body. All those things can still cause reactions. So you need to, when you're treating MCAS and when you're treating histamine excess, you need to approach it from multiple different angles in order to get a result. You can't just do one thing, such as take an antihistamine or just do a low histamine diet and expect it to help. You need to address it all around, get all the parts of it in order for it to resolve. And I'll be happy to do that for you. Happy to tell you what needs to be done if you'd like to schedule a consult, okay? So, somebody's asking about the difference between a stellate ganglion procedure that I do and a SGB. So it's technique. That's the difference, okay? the way I do it is different from the way we're taught to do it when we're in residency and fellowship. Okay, I've developed this technique over many procedures when I realized that the way we normally do it doesn't work as well, or it doesn't work well. So I have 100% Horner syndromes. Basically, 100% of the patients I do, basically before they even leave the procedure room table, they already have Horners. And most of the time when you do a standard stellate ganglion block, you have to wait a few minutes or even 5 to 10 minutes before you develop it, okay? And that has to do with the technique, okay? And I will be teaching this technique to other physicians in the future around the world. It's just I'm not ready yet. I don't have the infrastructure in place to be able to do that, but that is the plan. That's the plan. So I basically discovered a better way to do it. Is the best way I can explain it. Chelsea is asking if you're healed by SGB and EAT procedures, can it return with reinfection or more stress on the body? If you're exposed to something early on post procedures, yes, it can come back. Okay, and that is because it's still not repaired. So after the procedures, we get you to a state that's where you need to be, the normal state. However, you are not. It's still a fragile state. So there's things you need to do post procedure in order to stabilize and improve the state of your autonomic nervous system, the state of your mitochondria. And once that's set, you become way more resistant to developing long COVID again. Okay? I've had patients who managed to get a few months out before something triggered them again, and they were resistant. They didn't develop long COVID again because we did the right steps to strengthen their own systems to prevent long COVID, even though they were at risk in the first place. So it's kind of interesting to me that we can actually not just repair your systems, but also prevent long COVID from reoccurring. If you're still pregnant, Chelsea, or pregnant while this is happening, I typically do not offer these procedures during pregnancy, not because I don't think that they would work, but I'm just concerned about the baby. And, I wouldn't want to cause any problems, even though it's generally safe. Most procedures, elective procedures, are not offered during pregnancy. Okay, I'd be very happy to see you once you deliver, but I'll probably hold off until that point. Okay. Kristen is asking about IVIG. That's an interesting topic. IVIG infusions. IVIG can also be done subcutaneously. And hang on here. Role and potential. So she's asking about role of potential recovery of long vax-related autoimmune issues. So the autoimmune problems, again, occur from prolonged activation of the cGAS-STING pathway, in my view. And IVIG has a use with autoimmune conditions. It's not the first line, but it is a possibility. In terms of long COVID, though, I've only used IVIG in the context of small fiber neuropathy. If the small fiber neuropathy is caused by autoimmunity, and in some people with long COVID it is, IVIG is a useful therapy. However, you have to understand that while IVIG is covered for many different things under insurance, It is not covered for these purposes. It's not covered for long COVID. It's not covered for small fiber neuropathy caused by long COVID. And there is an expense, obviously, out-of-pocket expense, since IVIG needs to be repeated several times. I've done them as a session of 5 in a week, and you can do them about once a month going forward if we need maintenance. So the deal with IVIG is it's not completely benign, okay? And some patients can develop anaphylaxis from it, and there's other organ issues that can develop. So it's not a first-line treatment per se because of the side effect profile or risk profile. So it does have some uses, but you have to be careful in risk versus benefit ratio or the way it's presenting, okay? Julie is asking for consults performed virtually for out-of-towners, length of time required for procedures. Hang on, I just lost her thing. Here it is. Yes, how many length of time required for procedures, and what records do I need in advance? So the way I look at this is you can send me whatever you have, and I determine what else I need. So when I conduct a consult with a patient, I start with symptoms, okay? It's important to know what current symptoms are going on because it helps me determine which of the mechanisms are involved in your long COVID. Then I look at labs if you have them. I look at microbiome or stool sample microbiome if you have it, and will determine essentially which mechanisms need to be addressed. As far as procedures go, and sometimes I do order additional labs if needed, or if they weren't done, to help firm up my my diagnostics. Okay, as far as procedures, the shortest I would recommend would be 2 days. And the reason is if we're doing a stellate ganglion and EAT procedure together, I would do one stellate and then one EAT on one day, and then we would do a stellate on the second day if needed. And this goes towards dominance. So about 80% of people tend to be right side dominant when it comes to the stellate ganglion. And this has nothing to do with which hand dominant you are or which eye dominant you are. Your body just tends to pick one side to use more than the other. So we have two, right? We have one on the left and one on the right. And the majority of people, about 80%, tend to be right dominant. And you also have people who are left dominant and people who are non-dominant. So when we're talking about dominant, I'm not saying 100% of the communication occurs on one side and 0 on the other. I'm saying that the majority of the communication occurs on one side. And if you're non-dominant, about 50-50. So your body doesn't care, it can use either side. And in that case, you need to do both sides to have an effect. If you're planning on doing more than one EAT procedure, then I would recommend 5 days. So in other words, if your EAT score is high, if it's above 20, and we're planning to do more than one EAT procedure, then I would at least try to get 2 in. And I would recommend 5 days apart. It doesn't absolutely have to be done 5 days apart. I can do it every other day if needed. However, I should qualify that is your nose is going to be sore. The back of your nose is going to be sore if we do it every other day. I recommend a minimum of 5 days if it's possible. If it's not possible, I can do it every other day. Okay? So let's talk about intermittent fasting. Charlene brought this up. So intermittent fasting, and what I'm talking about is wet fasting, not dry fasting. Okay, and the difference here is that with wet fasting is you're allowed to take liquids that are 0 calorie. Okay, and then obviously the most obvious one is water. Water has no calories. I mean, obviously, don't put stuff in the water to give it calories, but it doesn't really impact the fasting state if you drink water. Okay, and we're mostly water, and limiting water intake as well as food intake will really upset your kidneys, and you could potentially get into acute renal failure if you're not getting sufficient liquid, especially water. So this is why I don't like dry fasting, okay? And it doesn't really alter the fasting state because there's no calories involved. So when you start fasting, whether it's a 16-8 or 18-6 or even a 48-hour fast, your body starts to recycle your own cells, in particular mitochondria. That's what's called mitophagy and autophagy. And anything that's damaged tends to be targeted first. And it breaks it down into its components, into proteins, amino acids, fatty acids, and such. And you can use it to make new things. Okay. The idea behind mitophagy is because when COVID infects you, when the vaccine is in you, it can damage your mitochondria, and damaged mitochondria release double-stranded DNA, right? And double-stranded DNA activate the cGAS-STING pathway, and that prolongs or continues the chronic inflammation that you're experiencing, and this is essentially what long COVID is. It's a period of chronic inflammation where your immune system is dysregulated, and your autonomic nervous system is dysregulated from the damage to the mitochondria. And that happens in the gut, and that happens in your throat and nose, and that happens throughout your body. And the idea here is to improve your mitochondrial function. Okay, so that's really what fasting is about. It's about treating the mitochondrial dysfunction that occurs. The mitochondria that didn't rupture are under excess oxidative stress, and that is because their efficiency has been reduced due to either damage to their DNA or damage to their mechanism, damage to the electron transport chain, damage to the Krebs cycle, and they're not using the fuel molecules such as a fatty acid or a glucose molecule or an amino acid to its fullest. So instead, they're spitting out highly reactive oxygen species, okay, that can oxidize other things, and they're generating heat, okay, but they're not producing as much ATP as they should be. And this leads to post-exertional malaise, this leads to fatigue, this leads to brain fog too. Okay, so that's really the issue with fasting. Why do I say 48 hours? Okay, because if you hit it too hard, okay, you'll have incomplete mitophagy. That is that if you go much beyond 48 hours, if you hit the mitophagy mechanisms too hard or too fast, these mitochondria will not be able to undergo complete mitophagy that is non-inflammatory, okay, where their DNA is not being released into the cytoplasm, where the cell is not being killed in a way that's generating more inflammation. We don't want that. If you hit it too hard, it's not going to be complete, and you will release the double-stranded DNA in the mitochondria, and you will release the nuclear material into your bloodstream or into your tissue. So this is what we're trying to avoid. So I like fasting. I like intermittent fasting. I don't like dry fasting, as I said. But my point is to limit it. 48 hours or less is what you want. That's kind of the sweet spot. If you go too much over, it will cause significant mitophagy and it will be incomplete, which means that you're going to have additional inflammation and it's going to undo what we're trying to do. Okay? If you have pain in the neck or shoulder, can you still do the stellate ganglion procedure? Becky asks. Yes, why not? that has no bearing. The only contraindication, okay, to doing a stellate ganglion procedure for me would be if you're on significant amount of blood thinners. And the reason is because you know, even the small blood vessels can continue to bleed, and you'll get what's called a hematoma, and it's going to be the size of a golf ball or the size of an orange, and it's not going to be particularly comfortable, and you can press on things that we don't want it to press on. Okay, it's a very tight area, and there's a lot of important structures in your neck. Outside of that, really the only other reason I wouldn't perform the procedure, it would be if there was a significant anatomical disruption, such as you had a huge cancer in your neck and they took out a chunk of tissue and things don't look normal anymore. And I wouldn't know, you know, one side from the other. Placement of fusion devices in the neck, doing the Aspire device for snoring, for obstructive sleep apnea. None of these things prevent me from doing the stellate ganglion block safely. Okay. And as I said, my technique is different, so I tend not to call it a block. I tend to call it a stellate ganglion procedure. Madeline is asking about, I guess, the differences between a standard stellate ganglion block and my stellate ganglion procedure, and if I block both C6 and C4. Yes, I do block C6 and C4, but it's really the technique that I use that makes it different. Okay? So let's see here. We got a question about supplements. So most of the time when I choose supplements, they're for a specific purpose. They aren't trial and error. And I'm looking to achieve a specific condition change. Okay, so when I select supplements, I focus on mitochondrial dysfunction, okay, and the different aspects of them. So some of the supplements I select would be for mitochondrial support, and obviously a big reliance on antioxidants. And some of them rely on mitophagy and biosynthesis, because we need to generate new mitochondria too. And other supplements I select for antihistamine purposes or mast cell stabilization. And yet another set of supplements I select for gut health, basically reducing leaky gut and improving the microbiome state. Okay, so I have a specific way of focusing on these, and it's not a one size fits all. There really is differences between patients depending what else is going on. Okay. Leslie is asking about if I recommend EAT procedure and the stellate ganglion procedure, no matter what LC mechanisms we have. Yes, recently I've decided that that's the way I'm going to go, and the reason is because this is what's driving the long COVID. It is in the back of your nose and is in your gut. Okay, this is what's driving the dysautonomia, and this is what is driving the mitochondrial dysfunction, and that makes everything else happen in long COVID. Okay, so it really doesn't matter if it's mostly one or the other, because it's still being pushed by these two areas. Jeanette is asking about EAT procedure and CPAP. So one is really unrelated to the other. So what you're going to see post-EAT, basically immediately after the EAT procedure is done, is you're going to have an increased amount of post-nasal drip and drainage. And that's actually a good thing, because we're washing away all this stuff. So this stuff is really stuck back there. You cannot wash it out with a neti pot. You cannot wash it out with a spray or even a nasal wash. It is really stuck back there, okay? So part of the therapeutic effect from EAT is the rubbing of the area. So I do this under direct visualization. That means I actually watch myself through a camera as I rub different areas. I know that I've gotten all the areas that I wanted to get, and I know how much force to use and everything from feedback by looking at it, okay? So no, it does not prevent use of CPAP, but like I said, it may cause some um, postnasal drip and drainage for the next few days as it washes things out, okay? Nicotine patch, my absolute favorite. So when I first started, I got all excited about the nicotine patch, about nicotine gum. Um, and all of this has been based on a 4-patient study that was non-blinded, and they saw some improvement in long COVID symptoms, such as brain fog, such as fatigue, and in some patients, even their taste and smell. So, of course, I got a bit excited, but the more I learned about nicotine, the more cautious I've become, and I don't recommend nicotine patch as often now. So, nicotine patch actually has some usefulness, okay? Short term, 2 weeks or less. Why? Well, it's a stimulant. Okay, that's the reason you have trouble falling asleep with nicotine, is it causes insomnia. It causes your heart rate to increase, right? It's a stimulant. Yes, it helps your brain work better, more alert, but that's because it's a stimulant, not because it's fixing something. Um, it can cause increased oxidative stress on your mitochondria because it is a stimulant. So what I'm saying is it's okay to use, but just short term. Not months, not years. I know people who have been on this patch for the last 4 or 5 years, and I think they're doing more harm. So nicotine does activate the CAP pathway, which is the cholinergic anti-inflammatory pathway. Okay, and it's a major pathway that helps reduce inflammation. However, it also can cause inflammation because of its mechanism. Okay, so it's a double-edged sword. I'm fine with you guys using a nicotine patch, but as I said, I recommend short term for a few days, up to 2 weeks, no longer. And I just basically told you the reason. Prolonged exposure to nicotine can potentially accelerate atherosclerosis in arteries and blood vessels. Okay. Ginger Perry asks, what particular microbiome test company? I use one. I'm hesitant to really say online or in public what I use, but they all work to some extent. What I'm looking for is, in particular, the zonulin. Okay, if you have excess zonulin being secreted or dumped, that tells me that you probably do have leaky gut. I'm also looking at lactobacillus species and bifidobacterium species specifically, because those two tend to be very low in long COVID. Uh, uh, we don't know why, but COVID tends to like those two and tends to destroy those two. So a lot of your gut has many ACE2 receptors, and COVID likes your gut a lot. Kristen asks about HBOT sessions. So kind of going back to the turbocharger analogy that I was using before, how many people have cars here? I'm looking for gearheads or mechanics who like to experiment with the engine and kind of improve efficiency. And has anyone tried putting an oxygen tank, 100% oxygen, instead of the air intake, putting oxygen in there? Any idea what's going to happen? Your engine's going to explode. There is overoxidation, okay? So there have been some studies showing some improvement in brain fog and fatigue, But when you're doing these HBOT sessions, what you're really doing is you're not only getting 100% oxygen by mask, but it's also being pressurized, typically to about 2 atmospheres. Now, if you're treating the bends, if you're treating an area that's not healing because of lack of blood supply, if you're treating carbon monoxide poisoning, absolutely, you have no argument from me. HBOT is useful. But my concern with hyperbaric oxygen therapy is the oxidative stress that you're putting on your body. Okay, so mitochondria will not really take in more oxygen than they need. The oxygen so the way oxygen is used by mitochondria, and this is really the main area where the oxygen from the air you breathe is being used. Okay, similar to an engine, to the way oxygen is being used in a cylinder of an engine, is in the mitochondria, it's really to receive the electrons that are being donated from the food. Okay, so the food particles go through, and there's excess electrons, and they need to go somewhere. These electrons can't just float around. And oxygen acts as a final receptor, and it forms water. Okay, it forms water. Ideally, that's what we want. So having more oxygen is not going to make the electron transport chain work harder, per se. But additional oxygen does act as an oxidizer. And it can oxidize fat, and then the fat can go through peroxidation and oxidize DNA and oxidize RNA and oxidize other fat molecules and proteins. And when it oxidizes, it changes the shape of them so they don't function normally. So oxidants are really bad. We are our own worst enemy, okay? Normally. Let's say in an ideal environment, 21% oxygen, we still generate oxidative species. We still have oxidative stress, and it comes from us. It comes from our own mitochondria, okay? Because mitochondria are not perfect, okay? They don't generate 100% efficiency. So for every glucose molecule, for every amino acid, for every fatty acid, you're not getting 100% ATP from those. It's about 40% efficient. Okay, so what happens with the other 60%? Well, sometimes your electron transport chain will kick out early intermediates. In other words, it won't make it all the way through to generate the ATP, and you only generate part of the ATP, and you kick out reactive oxygen species or radical, okay? And the other part is heat. That's how we generate heat. That's how we maintain our body temperature, is that the mitochondria, especially in brown fat, decouple the ATP production from the fuel input and generate heat instead, okay? So because we're our worst enemy, we don't need to help our bodies generate oxidative stress. We got enough on our own. We just have enough antioxidants internally, such as glutathione, such as superoxide dismutase, okay, that neutralize these excess radicals that float around. We don't need to add to this, okay? The more oxidative stress you generate, the more likely the mitochondria are going to be dysfunctional, the more likely they are to rupture and release the DNA. And again, we start with the cGAS-STING pathway. So you see how this is all cyclical. So if you're going to do hyperbaric oxygen, make sure you load up on antioxidants beforehand, okay? Limit the sessions, limit to how long they are, limit to how often you're doing them, okay? I know I got off on a tangent. I apologize. Madeline is saying that she still doesn't understand how my stellate ganglion procedure is unique. It's not something I can explain. It's like a picture. It's you need to see it to understand it, okay? As I said, my technique is different, okay? It's a technique that I developed. It is different from the usual technique that is taught and used by the majority or all of the people who perform the procedure. It's different, okay? That's the only way I can explain it to you. I will be teaching it in the future to other doctors, But right now, it's a technique that I developed after doing thousands and thousands of these, and I found certain things work better. Okay? That's the best way I can explain it to you. It's not something I can talk somebody through. What about methylene blue from mitochondria, Adam asks. And low-dose naltrexone for neuropathy. So methylene blue is an antioxidant. It can act as a surrogate if for the electron transport chain, for instance, for the first three complexes. So the electron transport chain has 5 complexes in all, and each complex uses a different mechanism for pushing protons out to create a gradient. And then this gradient is being used as protons come in, they get charged a toll, essentially, each time they come in. Now two down a gradient. And each time a proton comes through, we generate 1 ATP. Okay? So it can act as a surrogate for complex 1 and complex 3, for instance, to pass electrons as an electron transport. But you have to be careful with methylene blue because it has a few interesting side effects, one of which is serotonin. Okay, it tends to inhibit the enzyme that breaks down serotonin. And if you happen to be on another medication or another food or something else that is adding additional serotonin into your system, you have a potential of developing what's called serotonin syndrome, which can land you in a hospital. So there's a few other things to worry about with methylene blue. So I recommend you work with a physician that understands how methylene blue works and coordinate care with somebody medical and not do this yourself, okay? Red light therapy, Jane, and this will be our last question. I apologize, but we're at 11. Red light therapy, theoretically, red light therapy, probably more so infrared or near infrared, can technically work through the cytochrome, part of the electron transport chain, to improve oxygen utilization. Okay. Now the problem is getting that light down to where you need it. Okay, and light doesn't really travel through skin, through muscle, through bone, through tendons all that well. I mean, we're not transparent. So, the issue is yes, it works really great in a petri dish. If you put a couple of cells there and you shine a red light or infrared light or near infrared, sure, the cell is going to get plenty of exposure and you can measure the increased oxygen utilization. Okay, fair enough. Like I said, the issue is how far does red light, infrared light penetrate through the skin, penetrate through fat, penetrate through muscle, through tendon, through ligament, through bone. Okay, that's really the main issue here. And that's my biggest beef with light-based therapies. I mean, if we can figure out a way to get it into where we need it, sure, that there may be some improvement. I would vote for infrared or near infrared over red light, just because I think it will have deeper penetration. But what is infrared light? We're talking about the EM radiation spectrum, right? Electromagnetic radiation. It's really heat. So when you're hit by infrared light, you feel heat. This is how all these infrared heaters work. If you have something hot on a stove, it gives off infrared light that we feel as heat. Okay, that's all IR is. But anyway, my point is yes, I think it could be useful if we can find a way to get it to penetrate deeper. Surface exposure doesn't really do a whole lot. So there's potential for healing with some of these light-based therapies. There's been a few studies showing improved or accelerated healing. But really, with long COVID, our biggest problem is this fight-flight. Okay, I'm going to go back to the fight-flight because this prevents healing. If you're stuck in fight-flight, it's meant to be used sporadically, occasionally. It's not meant to be used 24/7. So when you're stuck in fight-flight, you're not healing. You're not digesting well, which means you have gastrointestinal problems. You're not repairing anything. So stem cells don't do anything. Let's say I know people who get stem cell treatments. Well, what are these stem cells doing? Your body is in survival mode. It's not in healing and repair mode. These stem cells, are there. That's great, but they really are not able to do anything because they don't have the right signals right now. Since your body is stuck in fight-flight, you don't have the right signals for them to be actually incorporated and actually treat anything and heal anything. Okay, so it's a waste of money. You need to treat the dysautonomia first. You need to get out of fight-flight first before you can actually heal from anything. And this is also why just about everybody needs a stellate ganglion procedure. Is if you cannot get out of fight-flight, everything else you do is not going to work or is not going to work well. Okay, so until you get out of that state, you can't really get better. All right, I'm going to conclude here, and I'll see you next month for another session. And I'll have a lot more information on the cGAS-STING pathway after I talk with Stacy. And again, just disclaimer, obviously nothing I say here is meant to treat or cure anything, because that's not allowed on a public forum. And there's a lot of new things coming. So if you haven't joined my group, see if you can find me on Facebook. And my website is covidinstitute.org. I've published 5 different books on long COVID, and actually 2 more are on the way. One is on hormones and hormones dysregulation, where there's a balance problem. And the second is the mitochondria book that everybody's been waiting for. Now, this book has given me nothing but grief because I have rewritten this book at least 3 times. And while I'm not completely happy with it, I am satisfied with it. And the main reason is because I'm always conflicted with how detailed I should get, and without losing people. And at the same time, some people want more. So since this book is very, very technical, for some, it may be difficult. So I'm trying to separate out kind of the bits that you need to know without getting into the down the rabbit hole, unless you want to. If you want to, it's there. If you don't, just read the stuff outside of the boxes, and you'll be happy. But long COVID is really a mitochondrial dysfunction problem, big time. And this book should really shed a lot of information and details on what's going on in long COVID. Okay? Thank you so much, guys, and God bless.